Hello friends, I am Dr. Deepak Garg and today we will discuss about proximal femur resection. So first we need pre-operative planning. Pre-operative planning we need to know three things. One, which are the muscles involved. Number two, the length of the bone resection. For example, if the tumor is 18 centimeter, then we will have to do 2 to 3 centimeter extra. We measure from the tip of the GT and we cut 20 to 21 centimeter, for example. And third thing is we need to know the neurovascular status with the tumor. We should know the distance of the tumor from the sciatic nerve and from the femoral vessels and the profunda vessels. So keeping this in mind, we plan the surgery. We keep the patient position in a lateral decubitus position, and then we do the painting draping. After painting draping, we mark the skin incision. So our skin incision is a lateral approach to the femur. So we mark the tip of the GT, and from the center of the GT along the shaft, we take approximately, depending upon the resection length, we mark the incision approximately 15-20 centimeter down the tip of GT and 5 centimeter above the tip of GT. So this is our skin incision. After the skin incision, we cut the subcute in line with the skin incision, and then we have the fascia. So we should always keep in mind the oncological aspects. So if the fascia is not involved, we will cut the fascia, and if the fascia is involved, we may have to sacrifice some part of the fascia. So after we cut the fascia, then we will have to we can use a Chanley's retractor here, so we will have a better exposure of the area filled. So now, depending upon the involvement by the tumor, for example, if the whole bone is involved, then we will have first we will have to we will cut the muscles from the femur. So for example, the proximal attachment of the femur, gluteus mediae, gluteus minimi, we may have to cut these muscles. We may cut approximately 1 centimeter, keeping a margin of the 1 centimeter from the femur, so considering the oncological aspect. Or if these GT is not involved by the tumor, we may do the osteotomy of the GT, so that later on we can attach this bone to the tumor prosthesis. Then we have the external rotators. External rotators we will have to cut. We will cut the external rotators, keeping a margin of the 1 centimeter of the external rotators from the bone. Then we have the gluteus maximus muscle. So we will have, this is a sling of the gluteus maximus muscle which is attached on the femur, and there is a very bleeder is there in the sling which may bleed profusely. So we have to be very slow during detachment of the gluteus maximus sleeve. So during the detachment of the gluteus maximus sleeve, we go very slow, and we identify that bleeder, we coagulate or tie the bleeder, and then we cut the gluteus maximus sleeve. So as soon as we cut the gluteus maximus sleeve, we retract the gluteus maximus muscle on the posterior and the lateral aspect. So we will then have the exposure of the sciatic nerve. Here we will have to separate the sciatic nerve. We will have to protect and separate the sciatic nerve. So after the protection of the sciatic nerve, we cut all the external rotators 1 centimeter away from the femur. So now we have done the resection on the posterior aspect, where we have cut the gluteus minimus, mediae, maximus, and the external rotators. Now we go on to the medial side. So here we can take the bone osteotomy. So let's say, for example, we have a resection length of around 21 centimeter. So we measure the 21 centimeter from the tip of the GT. We take a osteotomy of the femur here, and then we can easily hold the distal part of the femur with the bone holding forceps, and we can easily rotate the femur. So here we rotate the femur on the posterior aspect, so that we can make the medial structures taut, and then we start cutting the medial muscles. So the attachment of the adductors on the femur. So we again keep a cuff of around a centimeter and start cutting the muscle. Now about the joint involvement. So if the joint is not involved by the tumor, here we will have to take the capsular detachment. So we will cut the capsule along the circumference, considering the oncological margin. If the joint is not involved, then only we will have to open the joint. Otherwise we have to go extra articular resection. So then we cut the capsule, we dislocate the femur, and so now we have both the end free, proximal and distal. We have cut the circumferential capsule and lower down we have taken the osteotomy. So now we can make the adductors taut, and gradually we will cut all the adductors muscles. And then on the medial side we have the femoral vessels. We identify and separate the femoral vessels, and downside we have the profunda brachii coming from the femoral vessels, and these vessels, profunda femori. Then we identify these vessels, and if we are not able to protect them, we can ligate them also, but if we can protect them, we should protect them. And then gradually we cut all the adductors. Then the iliopsoas muscle is attached at the LT. We have to cut the iliopsoas. Then before cutting the iliopsoas, we tie the iliopsoas with the ethibond suture, so that later on we can attach them at the megaprosthesis. So this way we detach all the muscles, and then we will get the tumor specimen outside. And once we have the tumor specimen outside, we tag the specimen for the margins. We tag the short superior, long lateral. This is a normal tag that we do, and then send the specimen for the histopathology report. And then is the part of next part is a reconstruction part. So here, if we are planning for a megaprosthesis, we can use a megaprosthesis here. If we have done, we do the cemented megaprosthesis with the appropriate length. If you have taken 21 centimeter, you have to reconstruct 21 centimeter of the length. And after reconstruction, we have to attach all the muscles. So we have to, the external rotators we tie with the ethibond, and we attach at the megaprosthesis. And for the joint reconstruction, we use a proline mesh. So whatever structures, soft tissue is attached, remaining attached with the acetabulum. So we attach a double folded proline mesh over the acetabulum, and that we use as a capsule, and we tie it with the neck of the implant. And then we attach the iliopsoas muscle to there is a slot for the iliopsoas muscle in the megaprosthesis. We tie it there, and then we attach to the GT, the gluteus muscles, and the short external rotators. There is a slot for them, and there should be a proper reconstruction and the muscular reattachment, so that we can have a better functional outcome. So then we close the wound in layers. We put a drain. So post-operative, we look for the drain. When the drain is less than 50, we remove the drain, and around 14-15 days of the surgery, we remove the sutures. And chemotherapy, our main goal is that there should be as little gap between the chemotherapy sessions, like before surgery and after surgery. So we usually plan surgery at 10, 11, 12 days of chemotherapy, so that patient can start the chemotherapy as early as possible after surgery. So this was and about mobilization, we start the mobilization as early as possible. Maybe the next day of surgery, we mobilize the patient full weight bearing. So this is about the resection of the proximal femur. So if you have any doubt, please put it in the comment box. We will reply. Thank you guys. Thank you very much.